I want to welcome you to the SDOH Screening Tools for Public Housing Residents Learning Collaborative. We have been planning this series for many months, so we're very excited to finally get things started. So thank you for joining us today and for your participation in the coming sessions. In case you aren't familiar, the National Center for Health and Public Housing is an organization that conducts research and provides training and technical assistance and outreach to health centers that are located in or immediately accessible to public housing. With the support of the Health Resources and Services Administration, we're able to work directly with housing authorities and health centers and other organizations to improve access, quality of care, health equity, and ultimately improve health outcomes for public housing residents. And just a quick disclaimer that the information that we're presenting today and in the following sessions are our own. They don't represent the views of HRSA or HHS or the federal government. Before we begin, I just want to go over some quick housekeeping items in case you're new to the Zoom platform or in case you just need a reminder. We would like for this to be an engaging session. And at this point, I've emailed all of you a few times, so it would be nice to also see your face. If you feel comfortable, please feel free to turn your video on. And that's one of the reasons and the benefits of using the Zoom platform. You are muted right now, but we'll open that up during the Q&A so you can ask questions freely, but please only turn your mic on when you're speaking. In the meantime, if you would like to be unmuted, oh, hi, Madison, thank you for turning your camera on. If you would like to say anything, you can just use your raise hand icon and we will unmute you. We also have the chat open and we're going to use that extensively. We'll be doing some icebreakers through the chat in just a minute, and we'll be using chat for comments and questions throughout all of these sessions. So while you're, I'm sorry you don't have a camera, but while you're listening to the content, add your thoughts, add your questions as they come to you so that when we do get to the Q&A portion, you'll be ready to go. And if you do see something, you see a question or a comment, please by all means respond. The chat is a great opportunity to share ideas and challenges with your peers. And so just a reminder, when you do add something in the chat, just remember to send it to everyone so that we can all see it. Of course, take breaks when you need them, stand up, stretch. We all know how difficult it is to be staring at a screen for such a long time. The meeting is being recorded and the slides and the recording will be posted to Moodle, and I'll send you a follow-up email with those links as well. Moodle is the learning management system that we'll be using for this learning collaborative. If you haven't already done so, you can create an account and access the Moodle site. And there are some detailed instructions on how to do that in the welcome packet. But please let me know if you're having any trouble getting onto Moodle. One of the other benefits of using Moodle is that it also has an online discussion forum, so you can post any additional thoughts or questions that you might have, and everyone else will be able to see that there as well. This is the timeline and commitment. We're asking all attendees to commit to attending each of the 5 sessions of this learning collaborative, and we know that is a big ask and a big use of your time. But if you are unable to join live, you'll have access to the recordings. And if there's someone in your staff that you think a specific session would be valuable for them, you're welcome to share that recording and slides with your staff or have them join in your place if necessary. We would also like for you all to feel very comfortable with sharing with your colleagues. So please engage in the chat during the Q&A. We've also provided a template or a case presentation where you can describe the challenges that you're facing, and we can talk through any strategies or solutions that we've identified. This is using kind of a Project Echo type format where you have an opportunity to present to your peers during the Q&A. Okay, so again, my name is AAPCHO. I am the Director of Research Policy and Health Promotion here at the National Center. I've had a very long career in the social determinants of health, particularly in the intersection of housing policy, food and nutrition policy, and community development. And I started out working with the Robert Wood Johnson Foundation's Commission to Build a Healthier America, which was their first effort to raise awareness on the social determinants of health, and then went to Pew to work on health impact assessments with the Health Impact Project and overseeing all of the housing HIAs that they did there. In my current role, I oversee the quantitative and the qualitative research and evaluation efforts, as well as engage in training and technical assistance on a variety of subjects. Our target population are public housing residents. So there are many issues such as violence and behavioral health and access to healthy food and cultural competency, chronic health conditions that are critical for this population. So we spend a lot of time developing resources on those topics. And screening for the social determinants of health is important for public housing residents. It's also important for other vulnerable populations, and it's also a HRSA priority. So that's why we're engaging in this particular learning collaborative. I'm joined by Dr. Abdeen Noboyo Rios, as both practitioner and researcher. Dr. Noboyo Rios's career has focused in the fields of public health, education, community development, and cultural competence. You can tell that I am used to calling him Abdeen, not by his last name, because I just stumbled on his last name. I apologize for that. He has authored more than 50 publications in many areas, but most recently completed 2 major books on Latinos in education. He's had more than 40 years of experience working in various fields in 5 different states at the federal, state, and local community levels. He's also worked overseas in 4 different continents and in the South Pacific, and he currently resides in Puerto Rico. Altogether, he's earned 6 degrees from 4 universities, including Harvard, UC Berkeley, University of Illinois, and Connecticut State University. Maybe the only person that enjoys education and getting school more than I do. And I am very grateful that he will be co-leading and facilitating these sessions with me. Also joining us today, although they aren't pictured on the slide, but you can see their faces here, are 2 other very important NCHPH staff, Ms. Fide Pineda Sandoval, our research analyst, and Ms. Chantel Moore, who's our communications specialist. Fide and Chantel will be helping to manage the chat and the polling questions and making sure there are no technical issues. So we're really grateful to have their assistance today. Okay, so the agenda. This is our first session, so we have a lot of ground to cover. We're going to spend the first part of today going over the goals of the Learning Collaborative and walking through the topics of each of the sessions so that you can get a sense of what will be covered in subsequent meetings. Then we will begin to discuss the content for today's session, which is Screening 101. Abdeen will go through the definition of SDOH, the importance of screening, particularly for public housing communities. And then I'm going to walk through some of the typical SDOH domains that are covered in SDOH screening protocols and go through an example from North Carolina about their process. And then we'll get to the Q&A. So now Abdeen is going to lead us through the icebreakers.
This is an opportunity for you to enter your name and your role, as well as your health center name and city and state. We'll give you about 30 seconds to respond to this, and I'll do a countdown at the end, and you'll see.
Sorry, I was just trying to launch the poll.
On a scale of 1 to 10, with 10 being the highest, at what level of SDOH screening knowledge and competence would you rate your organization? All right, our results are in. We have around 14% of our individuals that reported they would rank it around a 4. 29% would rate it at 5, and 14% would rate it 6. 43% would rate 8. For question number 2, we had roughly 14% who said that they would rate it higher than other comparable institutions. 43% said about the same as other comparable institutions, and 29% said less than other comparable institutions, and 14% reported not sure.
Saki, we should probably go to the next slide. The summary of the reported data, as you see on this slide, is taken from your responses during registration about SDOH, and they fall into 3 major categories by column. The first are the SDOH challenges that most of you indicated about your organization. These were considerable. There were about 9 options, which range from insufficient time for screening to the fear of patient stigmatization for SDOH, to lack of patient trust, to that of insufficient staff to carry out SDOH responsibilities, to inadequate data utilization, to not having tools in Spanish or other major languages, to that of non-standardization of collected data, to lack of training, and finally to incomplete workflow integration. We will be taking some of these challenges through our various LC sessions in the future. As best strategies that have been identified by your organization around SDOH practices and policies, they were threefold. Greater education of staff and exposure to SDOH principles was number 1. Dispelling stigma around SDOH was another, and also ensuring fuller standardization of gathered data. As it regards to what you would like to learn from the learning collaboratives, these fell into 4 major categories: to better utilize collected data, to also gain greater understanding about best practices and helpful resources, to discover new strategies related to SDOH management and practice, and also to learn how to better approach sensitive issues around the social determinants of health. The following slide represent guiding questions that will drive today's learning collaborative.
Hold on just a second, Abdeen. Let me just quickly go over what to expect during the learning collaborative. Oops. Sorry. So thanks so much for filling out those registration questions. They really will help and were helpful in informing how we organized the sessions for this learning collaborative. I just want to go over what we're going to do for each session, and this material is provided to you in the welcome packet. These are the dates for each of the sessions. If you haven't already, please make sure you add these dates to your calendar, and you'll be able to access each of the sessions with the same Zoom link. So we already kind of talked about the agenda for session 1, which is just to cover the basics of SDOH and screening. Today, we're going to discuss the importance of screening for SDOH, the major domains of SDOH that are particularly important to consider for public housing residents. We'll also introduce the main steps of identifying appropriate screening tools and implementing a screening process. And in the later sessions, we'll go into those issues and topics in more detail. And the second session will be a guided tour of screening tools. There are several screening tools that are currently available, and it can be a real challenge to figure out which one is best suited for your health center and for your patient population. So in this session, we'll walk through the most common screening tools that are available and compare them using a standard set of criteria. And we're also going to be joined by Joe Lee from AAPCHO to discuss the Prepare tool. So Joe was and is a critical part of the Prepare's development. And so he's going to provide an overview of the tool and the resources that are available to learn more about its application. In the next session, we'll discuss the importance of screening SDOH to ensure that there's a comprehensive approach to health and well-being for women and children. Dr. Christina Bethel, who's the founding director of the Child and Adolescent Health Measurement Initiative, will discuss the early childhood cycle of engagement model and tools to build trust between families and pediatric primary care teams to optimize the well-being of all children. And I apologize if you can hear the lawnmower in the background. It's a little loud, but it'll go away. And then in the next session, we'll discuss the details of implementing a screening protocol and integrating it into EHRs, into workflows, into case management and referrals. Using mental health screening as an example, our guest speaker, Dr. Zara Marsalian from La Maestra Health Center, will walk everyone through the screening process from the health center perspective, and she'll discuss her experiences, her pitfalls, her lessons learned about IT and staffing and all the resources that are needed to successfully implement a screening protocol. And then in the last session, we'll discuss the practical aspects of screening for SDOH, the best options for reimbursement for SDOH related activities and referrals, how to engage in a thoughtful evaluation of quality measures that are impacted by screening practices. Dr. Marsalian from La Maestra will be joining us again, and she'll talk about a very important question of how are we going to pay for all of this. And she'll also discuss how her screening practices have improved the quality of care to her patients and other impacts that they've made to patient outcomes. And here are the names and roles of our guest speakers, and you can find their bios in the welcome packet for more information. And now we're going to start the content for session 1. Sorry, Abdeen, you can go ahead and the guiding questions.
Not a problem. The guiding questions, several of them. How did SDOH come about? How did it enter the field of healthcare? Why is SDOH important? How does SDOH assist clients and improve health outcomes? What is the role of screening tools? How are these helpful? What are best practices in the utilization of SDOH and screening tools? And how can this series of webinars, there are 5 in this series, help your everyday practice and further improve health outcomes for your organization?
And our objectives mirror those guiding questions. Our objectives are to understand SDOH in context and historical perspective, identify social risk factors that impact the health of public housing residents in their communities, describe the process of identifying and implementing an SDOH screening tool, and explain a procedure for linking patients to community-based and other social services and programs that address SDOH. For SDOH, we're using the Healthy People 2020 definition. Health starts in our homes, schools, workplaces, neighborhoods, and communities. We know that taking care of ourselves by eating well and staying active, not smoking, getting the recommended immunizations and screening tests, and seeing a doctor when we're sick all influence our health. But our health is also determined in part by access to social and economic opportunities, the resources and the supports that are available in our homes and neighborhoods and communities, the quality of our schooling, the safety of our workplaces, the cleanliness of our water, food, and air, and the nature of our social interactions and relationships. The conditions in which we live explain in part why some Americans are healthier and others more generally are not as healthy as they could be.
And now let's look at SDOH and its historical context. Most recently, the SDOH model, which is also known as the SDH model, requires that healthcare organizations address not only medical problems, but also environmental and social factors. These include housing, social conditions, as well as crime and violence, high poverty, access to healthy food, among other related factors critical to public housing. Now, before I go to the next bullet, the concern here is that these types of conditions, known as social determinants of health, are important impediments to achieving desirable health outcomes that must be assured for all patients. The next bullet, for all societies, the social determinants of health have always related to health outcomes. In the US, however, while SDOH has always been present, it just recently entered as an important area of concentration and documentation near the start of this century. While this is good and the field has expanded rapidly, it has been increasing nearly tenfold during the past decade. For many health organizations, SDOH has grown faster than the capacity of many of these organizations to adequately respond. Hence, the purpose of these learning collaboratives. Also, the impact of SDOH is felt more strongly among low-income and disenfranchised communities, as well as in public housing. The next slide shows us the context of SDOH. The management of SDH can be complex and multi-tiered. Some would say that dealing with SDOH, such as poverty, can be as difficult, if not more so, than the treatment of cancer or heart disease or other illnesses. One research study has stated that while it is heartening that health systems are now devoting attention to health's social determinants, they will need the same kind of discipline that has helped them develop biomedical therapies. That's a very major statement. Hence, the SDOH process requires extreme care and multiple systems for their application, as it should fully encompass patient care through accurate assessments of patient needs. So, viewed from a personal perspective, SDOH is more than just getting to see a doctor. Instead, it is one of uncovering social barriers that may also indicate that seeing a doctor by itself may still be insufficient to ameliorate fully health disparities. Other factors impact health that go beyond medication, proper diagnosis, and diet. So SDOH is truly about a patient-centered approach where one size fits no one. And before the next slide, let me say, undoubtedly, this process is greatly enhanced utilizing the right screening tools. Hence, our focus for today's learning collaborative. Now, the question is, why is this important? Let me give you some statistics very briefly. Well, it is critical to note that while 90% of healthcare spending is at either the hospital or at a doctor's office, in contradistinction, about 70% of an individual's overall health is driven by non-medical factors, primarily social and environmental factors, and the accompanying behaviors that are influenced by them. SDOH is therefore about working in tandem with patient needs and resources. Now, on the next slide, the role of race and culture for SDOH is major and it should be underscored. The role race and culture play are very important factors for SDOH, as wrongful applications may run counter to the culture of the end user and can make false assumptions about the caring process, such as assuming that all low-income cultures are alike or that a given cultural group is entirely homogeneous. Also, in response, healthcare organizations must take time to engage the end user in the planning process so as not to misdirect with faulty assumptions about any group. Now, a vivid example of SDOH is how racism can make patients sick, not figuratively, but also physically. And it does this to the extent that it not only limits options that people of color have in accessing healthcare, but also includes other facets of daily living, which impacts health outcomes such as powerful stress factors that also are labeled as SDOH. And before the next bullet, let me say Dr. David Williams, a research sociologist, recently developed a scale to measure the impact of discrimination on well-being and mental health, going beyond traditional measures like income and education to related factors like implicit bias, residential segregation, stereotypical thinking, and even the inclusion of institutional racism. These factors, as he indicates, not only create and sustain inequality, but also affect health and contribute greatly to patient well-being or lack of well-being. His conclusions are stark. So, in reality, the next bullet, racism by itself can foster a truly rigged system that systematically creates major disadvantages for certain groups in the US, as he well exemplifies in his research. For example, as related to income, in 2015, Blacks earned 59 cents for every dollar of income white families received. And for gaps in wealth, which is an even better economic indicator, the data are that for every dollar of wealth that whites have, Black families have 7 pennies and Latino families have 6 pennies. So with the last bullet, SDOH can help combat racism at both the individual level as well as at the institutional level. At the personal level, let me give an example, SDOH can combat inequality. In Huntsville, Alabama, where an HBCU has shown it can improve the health of Black adults by including health evaluation as a part of freshman orientation and giving students upon registration the tools they need to make healthy choices by providing for them an annual health transcript so that by the time they graduate 4 years later, they will have learned how to monitor their health condition long-term. Now, similarly, the SDOH process can be helpful at the institutional level, not just the personal level. Here, a monitoring process can help the institution track more meaningfully the progress of their patients from both a health perspective as well as an environmental perspective, which shows how social factors enter the picture of health. On the next slide, we will see the health picture of HUD-assisted adults. And I won't go through all of this, but in general, this health picture shows that adults in assisted housing have higher rates of chronic health conditions and are great utilizers of health than the general population by considerable margins, as compared with general health conditions such as obesity, disability, diabetes, COPD, and asthma, as compared with the general health conditions of HUD-assisted low-income renters, and then compare it to all adults. And we see that the differences are stark, with HUD-assisted adults ranking with greater health disparities by double and triple rates. But when we added cumulatively, the differences are even greater than those percentages. Slide 19 talks about and shows us the impact of housing on health. The next slide. And it shows how these differences are related dynamically. Reading from bottom to top on the left column of the graphics, policies and programs impact health factors, which in turn impact health outcomes. So as health outcomes indicate, length of life and quality of life can both be directly shortened or expanded by health outcomes such as health behavior like tobacco use, diet and exercise, and the like. These are influenced by clinical care, defined as access and quality of care, and as these also relate to social and economic factors as listed, as well as the physical environment. This is a very, very dynamic slide in terms of how all of these factors relate. The next slide kind of sums it up by telling us that the social determinants of health have up to 6 times the impact on health as compared to clinical care. A very, very major statements. So addressing social determinants requires collaboration across medical care, public health, and social service providers. So the next slide. What are some of the key factors in the implementation of SDOH? Among others, patient trust is key to the process of referral, going beyond traditional medical appointments. One example is the trust and high esteem that many promotoras de salud have established with local Latino families in their respective communities. As an example, the next bullet is understanding differentiated staff roles, which is also critical to the process. For example, those who perform the screening, and those who make the referrals, and others who follow up, as well as those who track and create accountability within the system, and so forth and so on for all other staff members. Throughout, there must be integration with different levels of needs that often occur concurrently. Here, case management is key. So in brief, SDOH is truly a dynamic process, as different from a laundry list of needs, and the screening tool is just a door opener, not an end by itself. This is the reason why, according to the last bullet, staff operate in lockstep fashion through patient-staff relationships, where the greater the frequency of interaction, the greater the understanding and empathy that is created, and the higher the trust that is built. So in a nutshell, as the next slide will show, SDOH helps the patient by obtaining services that are related to patient well-being and better personal health, by providing data that helps the agency and the care manager to better assist with the totality of patient needs, also by providing the patient-provider, improving the patient-provider relationship, and bolstering patient receptivity to better navigate and attain broader service utilization. So now let's step back just a moment and note how the health field has evolved as shown on the next slide. Using maternal health as a case in point, which we will be discussing much more in depth in future learning collaboratives, the field has undergone several transitions since about mid last century. It has moved from one of infectious disease and illness to that for the management of developmental and chronic health conditions. More recently, the field, especially for children's primary health care, the field has undergone additional transitions that now focus on early and lifelong development of health, as well as whole child well-being. And the current implications are that this now requires attending to both a medical model and a social determinants of health model. Altogether, these now represent new tools for screening and alternative methods for patient tracking and monitoring. And now we enter into a poll question.
Which of the following reflect the most accurate statements about SDOH? Choice 1, the impact of SDOH is more strongly felt among low-income communities and public housing. Choice 2, SDOH primarily focuses on a medical model of care. Choice 3, the social determinants of health always relate to health outcomes. Choice 4, race and culture operate primarily independently from the SDOH model. And lastly, we have choice 5. SDOH has a much greater impact on health than clinical care.
I just ended the poll.
Interesting responses. Chantel, I can review these. We have A, the first response at 83%, the second response at 0, third response at 17, fourth response at 8, and final response at 25. And the answers are it's A, C, and E that are most correct. So the percentages here are reflecting that, to the extent that on B response, it was 0%. And on D response, it was 8%. So again, based on what we just reviewed, A, C, and E are all correct statements.
Thank you so much, Abdeen, for that overview and for that question that made us think a little bit. So I am now going to discuss the major SDOH domains that you can consider capturing in your SDOH screening protocols. In 2014, the Institute of Medicine engaged in a 2-phase study to identify domains and measures that capture the social determinants of health to inform the development and the recommendations for meaningful use of EHRs. Standardized social and behavioral data in EHRs can provide crucial information about factors that are influencing health and the effectiveness of treatment. And that information is useful for diagnosis, for treatment choices, for policy, for healthcare, system design, and then also for innovations to improve health outcomes and reduce healthcare costs. Meaningful use in a health information technology context refers to the use of EHRs and related technology within a health center to achieve specified objectives. And achieving meaningful use also helps determine whether an organization can receive payments from Medicare EHR Incentive Program or the Medicaid EHR Incentive Program. So the first report, Capturing Social and Behavioral Domains in EHRs, specifies criteria that should be used in deciding which domains would be included. It identifies some core social and behavioral domains to be included in the EHRs, and it also identifies some domains that might be included for specific populations or settings, and those could be defined by age or SES or race or disease or other characteristics. And in the second phase, the report, they narrowed down the domains to be included in the EHRs, but it also includes some discussion on the implications of incorporating them into the EHRs, including the challenges and how to overcome them, as well as how to link EHRs to other organizations. So the committee decided on using the following criteria for domains to be given a high priority of inclusion in EHRs. And the first is the strength of the evidence of the association between the domain with health, the usefulness of the domain for management and treatment of a patient's illness, or to describe and monitor population health and make healthcare related policy decisions that affect the entire patient population, or for research to learn about the cause of illness, the predictors of outcomes of care, and the impact of interventions at multiple levels. The third is the availability of a reliable and valid measure of the domain, the feasibility, whether there's a burden that's placed on the patient or the clinician or the administrative team on time and cost for interface and storage. Sensitivity, that is, if patient discomfort regarding revealing personal information is high, or if there's increased legal or privacy risks. And then finally, accessibility of data from another source. So if the information from an external source is accessible and it meets the needs of patient care, then it wouldn't necessarily need to be included in the EHR. So here are the major domains that were identified. Socio-demographic domains such as sexual orientation, race, ethnicity, country of origin, education, employment, financial resource strain, and that refers to food and housing insecurity. Psychological domains, health literacy, stress, negative mood and affect, psychological assets. Behavioral domains, dietary patterns, physical activity, tobacco use and exposure, and alcohol use. And individual level social relationship domains, social connectedness and social isolation, exposure to violence, and then neighborhoods and communities. So the neighborhood and community compositional characteristics, which include socioeconomic and racial and ethnic characteristics, as well as some of those other items that Abdeen mentioned about Dr. Williams' studies, such as racial segregation. So the second report, they really narrowed down the list of domains and include race, ethnicity, education, financial resource strain, stress, depression, physical activity, tobacco use and exposure, alcohol use, social connections and social isolation, exposure to violence, and then the neighborhood and the community compositional characteristics. Just a reminder, some of these items would normally be collected in an EHR, but the IOM committee kept them here in this list just to emphasize the importance of the information. The report also discusses some of the challenges of documenting SDOH, including the accuracy of self-reported data, some privacy protection for patients, how to link data across systems and organizations, and also the kinds of resources that are needed to create and maintain the technological infrastructure of EHRs. And we're going to discuss many of those details in sessions 4 and 5, but I encourage you to download this resource and take a look when you get an opportunity. So here's the next polling questions. I'm just curious about what type of domains you all are currently tracking in your HR systems.
So which domains do you currently screen? Please choose all that apply. We have race and ethnicity, education, financial resource strain, stress, depression, physical activity, tobacco use and exposure, alcohol use, social connections and social isolation, exposure to violence with an emphasis on intimate partner violence, in neighborhood and community compositional characteristics, or not available. All right, our results are in. We have 91% that of individuals who reported that they screened for race and ethnicity. 73% said they screened for education and financial resource strain. 64% screened for stress and depression. 45% screened for physical activity. 64% screened for tobacco use and exposure in addition to alcohol use. 45% screened for social connections and social isolation. 45% screened for exposure to violence with an emphasis on intimate partner violence. 27% screened for neighborhood and community compositional characteristics, and 18% reported not available.
Thank you, Chantel, and thanks for filling that out. So it does sound like some of you all are looking at some of the socio-demographic characteristics, but then some of the other items such as intimate partner violence or neighborhood characteristics, not so much. So thank you so much for filling that out and giving us a sense of that. So next, I'm just going to briefly go over the main steps that the NC Department of Health and Human Services went through when they adopted a standardized set of social determinants of health screening questions to identify and assist patients with unmet health-related resource needs in North Carolina. So the state of North Carolina engaged in a complete system redesign when they transitioned their Medicaid and health choice programs from fee-for-service to managed care. And their Medicaid beneficiaries who would be enrolled in health plans that are responsible for care management. And the state included linking patients to programs and services that address SDOH as a component of the care management requirements. So this was an opportunity for the state to provide some guidance on a standardized screener to all of their teams. And they had some guiding principles. First, the screening questions had to cover domains that were clearly linked to health outcomes. Second, the screening questions had to be simple, brief, and applicable to most populations so that they could be easily integrated into workflows in a diverse and varied settings across the state. And the idea here isn't that it needed to be a comprehensive or an exhaustive screener, but that a positive response might trigger a more in-depth assessment that allowed for a greater understanding of specific needs and more targeted navigation to resources by a community health worker or a care manager or a social worker or someone else in the enabling services team. The third is that the questions had to be validated. They had to draw from best practices, and they must be written at accessible reading levels. And then the fourth, to the greatest extent possible, the questions should align with existing screening tools like the Bright Futures questionnaire or the Prepare tool or the Accountable Health Community tool. So their process was over the summer, they met with key stakeholders that were interested in SDOH or were already working on SDOH, and they conducted a literature review and they examined best practices related to screening and identifying SDOH. Then they reviewed screening tools and they identified priority SDOH domains that they wanted to include. And they decided on food insecurity, housing instability, transportation, and interpersonal violence. And then they compiled a list of validated questions from various screening tools to create their own standardized screener. Over the winter, they convened an advisory group of diverse experts to review and refine the questions. And they did that over 4 sessions through the winter. So here is the implementation process, and bear with me, this is a very dense slide, but again, I just want to highlight their process. We will go through these details of the steps in later sessions. So they created this universal standard screener called the Care Needs Screening, and And they provide guidance both on the number of attempts that will be made to get a Medicaid enrollee to complete the screener and then the time period when it must be completed by. So they want it to be completed within 90 days of enrollment. Then the results of the screening is sent to a primary care provider within 7 days. Again, which provider and a time period. Then they had a clear definition of what a patient with high unmet resources needs were. For them, it automatically includes individuals that are homeless or experiencing domestic violence, as well as those who report positive on 3 or more of those core SDOH domains. If an individual was deemed as high unmet needs, then they're sent to care management for that deeper assessment. Part of their implementation process includes identifying community resources, and that's key. After you have identified the social risks that your patient population is facing, and you begin to identify the appropriate interventions to address those social risk factors, it's important to remember that you don't have to develop all of your interventions in-house or do these on your own. Partnering with an organization who's already developed services and programs that address the social needs of your patients can be a great way to get your patient's social needs met, but also lessen the resource burden that's on your healthcare organization. And in many cases, there's really no point in recreating the wheel. And another key piece here is ensuring that the screening tool is translated into other languages, and that depends on your patient population. Again, I just want to point out the importance of connecting patients to community resources. One of the main concerns that we hear from health centers is, about the SDOH screening process is, I've screened my patients for a particular issue, and now what? It's almost irresponsible to identify a problem and then do nothing about it. And the state of North Carolina is essentially saying the same thing here to address that. They created a resource database and a social service integration platform. So this is a catalog of resources that's updated periodically, and it's available to all Medicaid providers. And the requirement for the platform is that it must enable patient referrals to community organizations and provide a feedback loop from the community organization that the patient was served, so that you can track utilizations and needs and timeliness of that data. So that's a lot of information that we just provided to you. Again, we will be going through all of these concepts in more depth with Joe and Christine and Zara, so you'll be able to get an idea of how to practically apply these concepts at your health center. We're going to pause here in case anyone has any questions, and you can unmute yourself. And I'm going to turn this to Fide to let me know if there are any questions in the chat.
So at the moment, we don't have any questions.
Okay, so I'm going to let you guys think of any questions. If you have any questions, you can add them to the chat or raise your hand. And I'm just going to, in the interest of time, just remind you that the next session is on May 2nd, where we'll be talking about some of the screening tools in depth, specifically Prepare. And I know a lot of you all mentioned that you are using the Prepare tool, and we'll have Joe here to talk about Prepare. So come with your questions on that, and don't, feel free to get into the weeds, because Joe's very much prepared to answer any kind of detailed questions. Here are some resources that I went over today. We also have some NCHPH resources that might be helpful for you, including an interactive map where you can see where your health center community ranks in terms of some of the social health, socioeconomic health factors compared to other counties in your state. And the reports that I mentioned before. And Fide, do we have any questions or raised hands?
No, not at the moment.
Okay, so in case not, I'm going to go ahead and put the evaluation poll up to make sure that gets answered. So feel free to answer this poll on evaluation based on our session today. And you can also share with us how you think, what you found most useful for this session in the chat, as well as what could be improved for us in the future. And you can do that just to organize, or you don't have to send that to everyone. But we really appreciate your feedback to help us be better prepared for future learning collaboratives. And please feel free to reach out to any of us if you have any questions that come up. You can also add them to Moodle as well. And here's our contact information.
Hi, I have a question.
Okay.
This is Donisha speaking from TCA Health. Hey, everybody. Hope everyone's having a great day today. I wanted to ask, as far as collecting data, most of us are already collecting it, but probably in various ways. And so I know that this is supposed to help us get a lot more strategic and streamlined, and having some validation when we are collecting this data intake or registration process. But once this information is collected and it's, cleaned and formatted and all the data visuals are created, is there any type of like funding or anything that's coming down the pipeline from a national perspective to actually fund programming or interventions to address these issues, especially when it comes to health centers that are directly connected to public housing?
That is a great question. And as soon as we are aware of any type of funding resources that are available to you all, we will let you know. I don't know anything off the top of my head, but I will follow up with my colleagues to see if there is any type of funding. Things change, and we don't know if things until they kind of come up. So if anything turns up, any kind of funding opportunities, we'll definitely share that with you all.
There is some funding, but it's very limited that I know of immediately, that I know we're using here in Puerto Rico. And that's disaster recovery funding based on CDBG funds. And these are available to community health centers as they are to other agencies. It could be substantial. And there are RFPs that are out. There's also additional monies that have been allocated for particular sectors. In Puerto Rico, we have had hurricanes, but we have also had earthquakes recently. And so those funds are called CDBG-DR for disaster recovery funds. That's one source. And I know that here in the island, it ends up being substantial funding.
Thank you for that.
All right, so we have one question from Stephanie Gomez. Can you please speak more on why health literacy was primarily listed under psychological domain and not another domain?
For the IOM report, I'm not exactly sure. Abdeen, do you have any thoughts on literacy?
Some of these can actually fall on multiple domains. So it's not exclusive either or. And a lot of it depends on the context of that domain, that is on particular information about that domain. And that is the biggest differentiator. Hope that helps.
Yeah, sorry not to have more information on that, but I can dig into the IOM report and send you something either by Moodle or to your email.
Saki, can you hear me?
But let me add, Saki, that's a very important question because it's going to come up over and over again. And I think it's one that will be more greatly addressed later, but it's one that we should keep in mind throughout. It's a very key question.
And Jose, did I hear you?
Yes. Hello, everyone. Jose Leon, colleague of Saki and Abdeen, and thank you for being with us this afternoon. I can take that question, and basically health literacy is associated or is linked to behavioral change. And behavioral change is is under the psychological domain. In order for patients to understand instructions, and in order for patients to change behavior, they need to have a better understanding of the instructions that they get from clinicians. As you may know, there are different assessments for patients, so you can measure the health literacy status of patients. So it can give you an idea on whether or not the patient will understand your instructions and will follow the instructions. So that's the reason why sometimes, and as been said, you know, I mean, it doesn't mean that they have to be under that category specifically, but that's the reason why sometimes it's listed under psychological, under the psychological domain.
Thank you. Very helpful. Yes.
All right, thank you so much, and Dr. Leon, and to Abdeen, and to Fide and Chantel, and to all of you all for joining us today. And we are at our time. And again, we will be sending out the recording and the slides to everyone, and look forward to seeing you guys on May 2nd. Thank you very much.
Thank you.
Goodbye.